Hi, welcome back. In this lecture, we're going to start talking about specific EMS system designs. Again, keep in mind the different levels of organization. We've spent some time now talking about national initiatives and thinking about the population and community aspect of EMS. Now we want to more specifically go to the organizational level. And as we continue, you'll see that we keep moving further down the triangle, and we'll talk about routines and competencies and of specific structures within an EMS system. To start out, this is the common view that people have about EMS organizations. They think of them in terms of hospital systems, fire-based systems, community systems, or even volunteer organizations. But you can see, even from this chart, back from 2003, by the National Association of EMTs, that if you look within the fire-based systems, there's public, private organizations in both. The same way with even fire-based. People don't usually think of private fire-based systems, but there's actually private companies that provide fire provisions. So the question with all this becomes, which system is the best model for delivering EMS to a given community? Well, when we think about EMS systems, we have to get a little more specific. Are we talking about pre-hospital care? Historically, there was a movement to start calling EMS pre-hospital care, and you even saw the premier peer academic journal of EMS today, Pre-Hospital Emergency Care, named after that. The predecessor to that, Pre-Hospital and Disaster Medicine, was thinking along the same lines. But there were people that came along and said, well, we do more than just pre-hospital emergency care. What about the non-emergency care? What about public health? What about public safety? Those aspects add in, and people suggested, well, we call it out-of-hospital care. But unfortunately, that didn't seem to fit well either, because we do a lot of things, and there's a lot of other organizations. You could look at home health, that's an out-of-hospital care. And you could also look at a primary care physician and say that's ambulatory out-of-hospital care. So those didn't seem to fit really well. So we kept looking at different components. We also do specialty care. We do critical care. And even the term EMS, when we talk about emergency medical services, again, it encompasses so much more sometimes, because we also refer to the emergency department care as part of emergency medical services, because they provide emergency medical services. So when we say EMS system, we need to be much more specific about the components that we're talking about. From our perspective for the course, I would like for us to think of it in this context. When we talk about an EMS system, we're talking about 911 ambulance service, non-emergency ambulance service, first response, dispatch and communications, medical oversight, critical specialty care transport, special events coverages, and even public education and safety, if that's part of what's built into a system. But all of those would be components of a system. And of course, we could encompass more, and some places do. When Dr. Paul Pepe was hired in the city of Houston, the system actually included oversight of the trauma service, the emergency department, and the pre-hospital care system. And he was charged with integrating all three. So you can see it really is dependent on the system, and you need to be clear and understand the system component in your system. However, anything short of the list you see here makes it very difficult when you start comparing systems, because you can't in a succinct way actually compare the cost to the quality of the care that's provided, because often you don't have a good representation of total costs, as we'll discuss. Another component of thinking about the EMS system is, what is the geographical market? And in terms of geographical markets, the thing we have to really keep in mind is that's important to understand, because it influences care in two ways. It influences care from the perspective of actually providing clinical care for patients and what type of clinical care may be necessitated in a given area, but also providing the geographical coverage. An understanding of the demography of the area is very important because of that. We also need to keep in mind the concepts from microeconomic theory. Milton Friedman proposed this concept of the invisible hand theory, which says the consumer determines who to buy from. They make that decision about what to buy and who to buy from based on quality. They decide what to pay for a given product or service. And as part of this transaction, they must be able to consider alternative products or services. They must have the knowledge to compare these products and services. And they must buy often enough that they're a good consumer based on all of the concepts above. Unfortunately, in EMS, this breaks down. Traditional microeconomic theory breaks down from the concept of most patients don't make the decision who to buy from. When they pick up the phone and dial 911, the expectation is that someone will exist and someone will be sent to provide care and service for them, and they don't actually make the decision who it is that's going to come to provide that care in most markets. They also don't do it really dependent on quality, because until the time they need the service, they often don't realize or really pay much attention to the system that actually is in place. They also don't decide what to pay. As we'll see in a second, that quite often that's done by the government in some scenarios, but in other scenarios that price is preset before they actually go out shopping for the service and need the service, and it's provided. So you can see all of these break down. In that regard, they're not able to look at alternatives. They're not a good consumer. So the invisible hand piece of microeconomic theory really doesn't hold with EMS, and instead something that does hold is the concepts of a public utility model, or potentially a monopoly for providing service. So we'll talk about those economic concepts a little more as we go through, but much more in the EMS finance class. Another concept, though, from microeconomic theory is important to understand is something called economies of scales. And basically, economies of scale say that as an organization grows, their fixed cost decreases, which means their average overall cost of providing service decreases the more volume increases. So the more patients you see, this is the easiest way to think of this, is that the more patients you see, the more revenue potentially that's coming in, plus you're not going to need replication of a lot of the administrative services that you currently have in place. So that total fixed cost doesn't change, but the revenue potentially does. So overall, your fixed cost, your average cost decreases. And this really appears to be true in EMS. The microeconomic or economies of scale concept appears to be true in EMS, but it doesn't optimize until you reach a market size of about 1 million people. So if you take, for example, most of the EMS services in the state of North Carolina that are third service providers, most are nowhere near the economies of scale. If you're interested in the economies of scale and the potential cost benefit that could be derived from that, you may want to speak with Dr. Hubble, as his dissertation project actually involved looking at the cost benefit of regionalization of EMS within a region within the state of North Carolina. So let's look at a couple of these other issues that are important in defining an EMS system. One is the financing strategies that are used. Some EMS organizations finance completely from local tax subsidy. Unfortunately, or fortunately, you're seeing the number of those decrease. The ones that you still see that occasionally do that are fire-based systems within a municipality. There's also a funding strategy of governmental insurance funding, which comes in the forms of Medicare and Medicaid funding, which are primarily fundings that are locked into place. They're predetermined based on the type transport. So regardless of what you charge for service, you're going to receive a certain degree of funding or reimbursement from the governmental insurance sources. There's also private insurance. And often organizations don't capitalize on private insurance as much as they can, especially ones that depend to a large extent on tax subsidy. The way to think about it is this: if your patients are paying for private insurance and you don't capitalize on that potential funding source, then basically that patient's paying for the service twice. They're paying insurance to cover a potential transport or needed transport, as well as paying tax and their local community to help provide local tax subsidy for providing the system. So they're paying for it 2 times. So that's something to keep in mind. There's also private pay, and it's important to understand private pay and keep that concept in mind, as often when there's shortfalls in revenue or funding for funding projects within EMS systems, the thought is, well, we can simply raise the price that we charge our customers or our patients. Unfortunately, that doesn't work in most scenarios. Even if you double the cost, even if you double the price that you charge, and again, cost and price aren't the same thing. Cost is what it actually costs to provide the service, and price is probably and likely something much more than that already to cover unfunded care or to cover delinquent bills. But you can increase the price. Private pay is also important to understand, because often when you think about private pay, you think about the cost or the price that you actually charge for a given service. And when funds start to run short, often agencies think, well, we'll simply increase the price we charge. But unfortunately, increasing the price may not increase your revenue. The price charged versus the price that's actually reimbursed can be very different, especially with the governmental insurance sources that we talked about earlier. But with the private pays, it may be that that's a small portion of your total case mix, the number of patients you have in any given one of these categories. So it may not influence it very much at all. So we'll talk about that. There's actually something we'll talk about in the EMS Finance course called subsidy price trade-off, where we'll actually look at the trade-off between local tax subsidy and the amount that needs to be charged, and the way you get at that by understanding the case mix. And then finally, there's managed care. And you may think, well, there's not a lot of managed care contracts, but there actually are quite a few. One example of one that's currently in place is in Northern California. In Northern California, Rural Metro has a contract to transport all non-emergency patients that are Kaiser Permanente patients in Northern California. So there's a multi-county contract in place, multi-million-dollar contract in place for multiple counties to provide this non-emergency service. So you do see managed care contracts, and being able to enter into those is kind of an art in and of itself, because you really have to be good at forecasting how many transports you think you may need, because one of the ways that those contracts historically have been put in place is you're paid a certain percentage or a certain amount, a small amount per patient per month. So you've got to be able to predict, based on the patient volume, how many transports you think you'll provide, to know what you're going to charge and what revenue stream you're going to have on a monthly basis for providing the service. And the problem with that is that many local governments can't enter into a contract in a way that they can actually be responsible for the tort that could take place and take on the responsibility legally of the contract and go at risk. Because what would happen if the number of patients you have actually doubles compared to the amount of money that you're going to generate in a given month? Well, you're going to have to add resources quickly to be able to cover the expansion of service and to be able to cover those patients. And unfortunately, in most governmental organizations, the bureaucracy of going through doing that is just so long that you can't compensate or grow or change fast enough. So we'll talk about that more also. From the public perspective, you may say, well, I'm for public EMS system types. Well, there's multiple types, so you should really understand those. There's fire-based civilian, where the fire service actually goes out and hires EMS personnel as kind of a side group to provide emergency medical care. There's fire-based cross-train, where individuals are cross-trained to do both roles, but usually assigned to one or the other. There's fire-based alternative dual roles, where you're trained as both a firefighter and a paramedic, and you come in and one day you do one task, and the next day you may come in and do the other task. There's fire-based simultaneous dual role, wherein you come in and maybe there's an ambulance and a fire truck at the station, and usually you see these in really small communities or really low volume areas, but there'll be an ambulance and a fire truck in the station, and depending on what type of 911 request comes in, you'll take either the ambulance or the fire truck to respond to the call, whichever is appropriate. So you will do both at the same time. Then, of course, there's governmental third service that most of you are familiar with, because that's kind of the predominant mode of delivery here in the state of North Carolina. And then there's the public utility model, which is to some extent a combination of all of these above, plus the private models. The concept of public utility that makes it a public model is that there's a public agency or department that's responsible for providing the service, even though they may contract out for the actual structural parts or pieces. An example would be if you work for a third service provider now, the county EMS agency becomes just this oversight, the management. They may provide the education and training, they may provide some dispatch services, but primarily the service they provide is oversight to make sure the system is operated correctly to provide the service that's needed. And they may contract out part of that, be it the ambulance piece, from a private company, or they may contract with local fire agencies to provide that service. A good example of this system is the Pinellas County, Florida system, whereby there's 19 ALS fire departments that provide paramedic first response, and then there's a paramedic level transport agency, Sunstar Ambulance, which is actually Paramedics Plus Ambulance, is a subsidy of Paramedics Plus Ambulance, that provide paramedic level transport services and critical care transport services throughout the entire community. Then we have the private models. There's the non or not-for-profit hospital or rescue squad models. There's the privately held models, which are usually start out as small, locally owned entrepreneurial ambulance services, but they can also be some of the bigger, larger organizations as well. Historically, the next level here, the publicly traded, Rural Metro and American Medical Response, were publicly traded companies, which means that they actually had, they issued stock to generate revenue to help fund their growth. And in return, as profits come in, the stockholders are paid dividends for the shares of stock they own, and hopefully the valuation of the company increases such that if they decide to sell the stock, they actually generate capital gains from doing that as well. Well, you see some of the larger companies actually switch back and forth between these two types, the privately held and the publicly held. An example being Rural Metro. Rural Metro has since been bought out by a private equity firm, so it's in essence a private held company again, not a publicly traded entity any longer. And then finally there's the employee-owned systems. This happened years ago in Kansas City, where they were actually going to contract out for service, and the employees, a consultant went to the employees and suggested that they actually consider running the system. The difficulty in employee-owned is if the system didn't operate beforehand, there's really no track record of their management capabilities, so no one knows how they would actually be able to run the service. So if you were to go in and contract as an employee group, there's no assurance there that the employees would actually be able to pick up and run the system. So we can talk about that more. But now with some of the social innovation models and movement towards conscious business opportunities. You're starting to see a lot more of employee input. So you may see a resurgence of some of these employee-owned or at least employee managed organizations. So if we look at all of these different types, there's the 5 basic funding strategies, there's the 6 basic public types, there's the 4 private types. So needless to say, there's a lot of models. So this is just another level of the complexity that that exists when you're talking about an EMS design and it being the optimal design. So last week in the Facebook group, I actually asked you to kind of outline your ideal EMS system. And you probably said a fire-based system, or you said a third service provider, or something of that sort. But quite often people don't know the level of complexity that exists with a lot of these other levels. So it's been estimated that there's over 50 different types of EMS system designs. So there's a lot of complexity to it, and we'll keep building on that as we start talking about some of the structural features. But another thing I want to mention in this lecture before we move on to the structural features is something known as high-performance EMS. In 1975, at the University of Oklahoma, the Center for Economic and Management Research, a gentleman by the name of Jack Stout and a couple other economists actually decided to look at the industry and try to determine what was the best model for providing EMS. And when they did that, they analyzed both emergency and non-emergency transports. They looked at the peak load production problem of demand actually varying by time of day, day of week. They also looked at the fact that often people developed systems thinking that you couldn't predict how many ambulance calls would take place, but unfortunately, or fortunately, you can. You can actually predict pretty accurately how many ambulance calls are expected within a given time frame. So this ability to predict, especially in larger populations, was very beneficial in looking into optimal design. They also looked at the concepts we talked about earlier in terms of the microeconomic transaction being fragmented and the consumer function of that not being what it is normally in the normal microeconomic transaction. And then finally, they looked at this concept of cream skimming, where what they found was that in a lot of situations, someone would want to pick the piece of the system off that seemed to serve their purposes the best, whether that was generation of revenue, running certain types of ambulance calls. And you would think now, this number of years later, that we would be at the point that we'd move beyond that. But you still see it. Recently, I had the opportunity to be engaged by a city in Florida to actually help develop the request for proposal for contracting for ambulance service. And as part of that, the local fire service actually wanted to pick out part of the EMS calls. What their suggestion was is that the fire service paramedics would respond to all of the trauma calls within the context of the city, and then they would actually allow the ambulance provider, who was a private paramedic provider, to respond to all of the medical requests within a community. So again, you still see cream skimming take place even today. When we talk about high-performance EMS systems, the definition that was given to it is a system that the public's assured of clinical excellence, response time reliability, economic efficiency, and customer satisfaction, all simultaneously. So we're looking at all 4 of these components, and it truly has held the test of time that these 4 components become some of the most important features to look at in communities when designing an EMS system or running an EMS system. Now, there were some other hallmarks they identified as part of high-performance EMS, and they were accountability for the services provided. Now, if you remember, we talked about in a previous lecture, outcomes. There wasn't a lot in terms of clinical excellence, in terms of clinical outcomes, but there is a lot in terms of clinical processes. So it was the accountability of having people that were educated and trained at a certain level, providing care, meeting certain response time reliability requirements, etc. And all of those things the agency was held accountable for. Also, there was independent oversight, an oversight committee that could look at what's best for the public and actually assure that that was taking place. There was this understanding of the need to account and understand all costs in the system. Again, if we fragment the system and look at individual parts of it, it's hard to understand the overall cost to the community. And as such, if you're looking again as value to the community being high-level quality at low cost, it was difficult to assess that and compare systems. So again, it even further degraded from the microeconomic transaction and how that's evaluated. Require system features that ensure economic efficiency. Those things should be built into the system, such as accounting of all of the cost. And then assure long-term performance and sustainability was another feature or a hallmark of a high-performance system. They looked at the long term and actually planning for that. So as we go through and we move from looking at structure to looking at specific tasks, say for instance fleet maintenance, we'll keep these in mind in terms of the accountability, accounting for all the costs, and specifically looking at the long-term performance and sustainability and looking at what's best over the long term. And I realize that a lot of these things aren't in place, but what we want to talk about is where EMS needs to go in the future and how you can utilize the skills that exist today to actually help move it in that direction. So I want to stop there for this lecture. We'll pick up at the next lecture. Since we've talked about some of the strategic components, now in the next lecture we want to start talking more about the specific functional components of an EMS system. In the meantime, if you have any questions, please post them to the Facebook group or give me a call or send me an email.